In the concept of sensory, there are exemplars: cataracts, conductive hearing loss, macular degenerative disease, peripheral neuropathy, sensorineural loss, glaucoma, and eye injuries. The concept of sensory, cataracts is an exemplar. A cataract is a lens opacity or cloudiness. It affects nearly 24.4 million Americans who are 40 years or older. Cataract is a leading cause of blindness in the world. The medical management would include the risk reduction of cataract formation, having the patient with smoking cessation, weight reduction, blood sugar control for diabetic patients, and wearing of sunglasses. Surgical intervention is an option. A non-surgical treatment, such as medication, eye drops, or eyeglasses, cures cataracts or prevents age-related cataracts. With the exemplar of cataracts, there is surgical management, and there's a teaching chart, 63.9, in your Hinkle ebook under Home Care Checklist, page 1861. It suggests for the patient to wear glasses or eye shields after surgery, avoid lying on the side of the affected eye, keeping activity light, avoiding pushing, lifting objects heavier than 15 pounds, and definitely knowing when to contact the ophthalmologist. They need to contact the ophthalmologist if they have any vision changes, continuous flashing lights, redness, pain, or swelling that increases in the affected eye drainage changes, eye that gets injured, and pain not relieved by acetaminophen. Within the concept of sensory, the exemplar conductive hearing loss has many factors. Numerous factors contribute to the hearing loss. Noise-induced hearing loss refers to hearing loss that follows a long period of exposure to loud noise, such as heavy machinery, engines, artillery, rock band music. Acoustic trauma refers to hearing loss caused by single exposure to an extremely intense noise, such as an explosion. Usually noise-induced hearing loss occurs at a high frequency. However, with continued noise exposure, the hearing loss can become more severe and include adjacent frequencies. In Chart 64.4, communicating with people who are hearing impaired, there are many opportunities to understand and learn how to communicate with people who are hearing impaired. Determine how the person prefers to communicate with others. Consider if the person uses sign language, if they need an interpreter. Devote full attention to what the person is saying. Look and listen. Do not try to attend to another task while listening. Try to determine the essential content of what's being said. Do not try to appear as if you understand and you do not. Ring communication is an excellent resource. Before communicating, it's best to reduce noise or distractions. And during examinations and testing, be aware that the patient may not hear instructions. They may not read lips, see a signer, or even be able to read written material in dark rooms. Within the concept sensory, there is macular degenerative disease as an exemplar. Age-related macular degeneration is the most common cause of visual loss in people older than 65 in the United States. It's characterized by tiny yellowish spots called drusen beneath the retina. Most people older than 60 have at least a few small drusen, which are clusters of debris or waste material. When drusen are located in the macular area, they can affect vision. There is no cure for the dry, non-exudate type of macular degeneration. The National Eye Institute is sponsoring an ongoing clinical trial to study the effect of lutein in carotenoids or fish oils in protecting the macula and preventing the progression of macular degeneration. Wet exudate is characterized by the development of an abnormal choroidal neovascular network beneath the macula. These vessels leak fluid and bleed, causing edema and the development of fibrosis. If either the dry or the wet are not cured, it will result in a loss of central vision. In nursing management, an Amsler grid is given to patients to use in their homes to monitor for a sudden onset or distortion of vision. They may provide the early sign that macular degeneration is getting worse. Patients should be encouraged to look at these grids, one eye at a time, several times each week, with glasses on if needed for corrected near vision. If there is a change in the grid, meaning the lines or squares appear distorted or faded, the patient should notify their ophthalmologist immediately and should arrange to be seen promptly. With the concept of sensory, the exemplar peripheral neuropathy will be explained. Now, there is diabetic neuropathy, which refers to a group of diseases that affects all types of nerves, including peripheral, sensory-motor, autonomic, and spinal nerves. The disorder appears to be clinically diverse and depends on the location of the affected nerve cells. The etiology of neuropathy may involve elevated blood glucose levels over a period of years. Control of blood glucose levels to normal or near normal levels decreases that incidence of neuropathy. The pathogenesis of neuropathy may be attributed to either a vascular or metabolic mechanism or both. Capillary basement membrane thickening and capillary closure may be present. In addition, there may be demyelinization of the nerves, which is thought to be related to hyperglycemia. Nerve conduction is disrupted when there are aberrations of the myelin sheaths. The clinical manifestations will include initial symptoms that could include paresthesia, which is prickling, tingling, or heightened sensation, burning sensations, especially at night, and as the neuropathy progresses, the feet become numb. In addition, a decrease in proprioception, which is the awareness of posture and body movement and the weight of objects in relation to the body, and a decreased sensation of light touch may lead to an unsteady gait. On physical examination, a deep dendon reflex and vibratory sensation is found. For patients who have few or no symptoms of neuropathy, these physical findings may be the only indications of neuropathic changes. Within the management, we would like the patient to have intensive insulin therapy and control of blood glucose levels so that it will delay the onset and slow the progression of neuropathy. Pain, particularly of the lower extremities, is a disturbing symptom in some people with neuropathy secondary to diabetes. There have been various approaches to pain management, and they have been tried. Such can be non-opioid medications, tricyclic antidepressants, anti-seizure medications, antiarrhythmic agents, and transcutaneous electrical nerve stimulation. In the concept of sensory, the exemplar glaucoma has nursing management, which includes patient education. There is a chart on 63.6, Managing Glaucoma, in your Hinkle ebook, page 1857. Know your intraocular pressure measurement and the desired range. Be informed about the extent of your vision loss and optic nerve damage. Also educate the patient about the strict medication regimen. Their medications can have interactions with other medications, such as if they take Diamox, it has a diuretic effect. If they take miotics, it can alter their focus. Also, the disease has a familial tendency. What is prescribed and what is recommended is to have family members' eye examinations once every 2 years. Within the concept of sensory and the exemplar glaucoma, we'll continue the nursing management. Medications used in the management of glaucoma include cholinergics, which increase the aqueous fluid outflow by contracting the ciliary muscle and causing meiosis, which is the constriction of the pupil, and the opening of the trabecular meshwork. Beta blockers are another medication which decrease aqueous humor production. Alpha adrenergic agonists decrease aqueous humor production also. And carbonic anhydrase inhibitors decrease aqueous humor production. And prostaglandin analogs increase uvulosclera outflow. With administering eye medications, there is a chart, 63.5, titled Patient Education in the ebook Hinkle. What is important is to perform hand hygiene before and after procedure. Ensure adequate lighting and obviously read the label of the eye medication to verify that it's correct. Remove any contact lenses and have them assume a comfortable position. Hold the lower lid down, do not press on the eyeball, and apply gentle pressure to the cheekbone to anchor the finger holding the lid. Now you instill the eye drops before applying ointments. And what you do is you apply a ribbon of ointment to the lower conjunctival sac. And then keeping the eyelids closed, apply gentle pressure on the inner canthus for 1 or 2 minutes, immediately instilling eye drops. Using a clean tissue, gently pat to absorb the excess, and then you must wait 5 minutes before instilling another eye drop, and 10 minutes before instilling another ointment. After all is done, you can reinsert contact lenses if applicable. What would be essential in understanding if the patient is able to do this, I would have the patient demonstrate the installation of the medication after they've been educated to ensure proper demonstration and proper understanding. In Chart 63-7, in Patient Education titled, and Managing Glaucoma, it would be essential to educate your patient to be informed about the extent of their vision loss and optimal nerve damage. Educate them to review all of their medications, including over-the-counter and herbal medications, with their ophthalmologist, and have them mention any side effects each time they visit. Have them ask about potential side effects and drug interactions of their eye medications. Have them review their dosing schedule with their ophthalmologist, and have them inform their ophthalmologist if they're having trouble following the schedule. Advocate for them to participate in their decision-making process. Have them be aware that the glaucoma medications can cause adverse effects if used inappropriately, and that eye drops are to be administered as prescribed, not when eyes just feel irritated, and have them keep all their follow-up appointments. In the concept sensory, the exemplar has eye injuries. There's orbital and ocular trauma. Whether affecting the eye or the orbit, trauma to the eye and surrounding structures may have devastating consequences for vision. With orbital trauma, injury to the orbit is usually associated with a head injury, hence the patient's general medical condition must first be stabilized before conducting an ocular examination. Only then is the globe assessed for soft tissue injury. During inspection, the face is meticulously assessed for underlying fractures, which should always be suspected in cases of blunt trauma. To establish the extent of ocular injury, visual acuity is assessed as soon as possible. Soft tissue orbital injuries often result in damage to the optic nerve. Major ocular injuries indicated by a soft globe, prolapsing tissue, ruptured globe, and hemorrhage require immediate surgical attention. The soft tissue injury and hemorrhage from blunt or penetrating trauma includes tenderness, ecchymosis, lid swelling, and abnormal protrusion of the eyeball. Closed injuries lead to contusions with subconjunctival hemorrhage, commonly known as black eye. With orbital fractures, they are detected by facial x-rays. Depending on the orbital structures involved, orbital fractures can be classified as blowout, zygomatic, or tripod, maxillary, midfacial, orbital apex, and orbital roof fractures. There's foreign bodies that can enter the orbit that are usually tolerated except for copper, iron, and vegetable materials, such as those from plants or trees, which may cause purulent infection. X-rays and CT scans are used to identify the foreign body. With ocular trauma, it is a leading cause of blindness among children and young adults, especially male trauma victims. Ocular trauma occurs with occupational injuries like construction, industry, contact sports, weapons like air guns and BB guns, assaults, motor vehicle crashes, and explosions. A study of military personnel in the Iraq and Afghanistan wars revealed closed-eye ocular injuries that included foreign bodies, angle recession, retinal tears, and optic nerve atrophy. A thorough history is obtained, particularly assessing the patient's ocular history, such as pre-injury vision in the affected eye or past ocular surgeries. With splash injuries, they are irrigated with normal saline before further evaluation occurs. In cases of a ruptured globe, psychoplegic agents that paralyze the ciliary muscle, or topical antibiotics must be deferred because of potential toxicity to expose intraocular tissues. There are two types of ocular trauma in which the first response is critical, a chemical burn and a foreign object in the eye. With a chemical burn, the eye should be immediately irrigated with tap water or normal saline. With a foreign body, no attempt should be made to remove the foreign object. The object should be protected from jarring or movement to prevent further ocular damage. No pressure or patch should be applied to the affected eye. The concept cognition includes the exemplars Alzheimer's disease or dementia, which we'll also discuss vascular dementia, delirium, and Down syndrome. Alzheimer's disease is the fifth leading cause of death for older adults. It is a progressive, irreversible, degenerative neurologic disease that begins insidiously and is characterized by gradual losses of cognitive function and disturbances in behavior and affect. It can occur in people as young as 40 years of age, but is uncommon before 65 years of age. Although the prevalence increases dramatically with increasing age, it affects as many as half of those 85 years and older. It is to be noted that it is not a normal part of aging. Without a cure or any preventative measures, it is estimated that 13.4 million Americans will have this disease by 2050. With the pathophysiology, there are specific neuropathogenic and biochemical changes that are found in patients with Alzheimer's disease. These include neurofibrillary tangles, or senile or neurotic plaques. The neuronal damage occurs primarily in the cerebral cortex and results in decreased brain size. Similar changes are found in the normal brain tissue of older adults, although to a lesser extent. Cells that use the neurotransmitter acetylcholine are primarily affected by Alzheimer's disease. At the biochemical level, the enzyme active in producing acetylcholine, which is specifically involved in memory processing, is decreased. Now, the clinical manifestations show in the early stages are forgetfulness and subtle memory loss. Patients may experience small difficulties in work or social activities, but have adequate cognitive function to compensate for the loss and continue to function independently. With the further progression, the deficits can no longer be concealed. Forgetfulness is manifested in many daily actions. Patients may lose their ability to recognize familiar faces, places, and objects, and they may become lost in a familiar environment. They may repeat the same stories because they forget that they have already told them. The ability to formulate concepts and think abstractly disappears. On a hot day, a patient may decide to wade in the city fountain fully clothed. Patients may have difficulty with everyday activities such as operating simple appliances and handling money. Personality changes are also usually evident. They may become depressed, suspicious, paranoid, hostile, and even combative. With the medical management, the primary goal is to manage the cognitive and behavioral symptoms. There is no cure. There are several medications that have been introduced to slow the progression of the disease. The cholinesterase inhibitors, like Aricept and Exelon, enhances acetylcholine uptake in the brain, thus maintaining memory skills for a period of time. These and other medications are used for mild to moderate symptoms. Cognitive ability may improve within 6 to 12 months of therapy. However, cessation of the medications results in disease progression and cognitive decline. The behavioral problems such as agitation and psychosis can be managed by behavioral and psychologic therapies. Associated depression and behavioral problems can also be treated pharmacologically if other interventions fail. Because symptoms change over time, all patients with Alzheimer's disease should be reevaluated routinely. In Alzheimer's disease, nursing management plays an important role in the recognition of dementia, particularly in hospitalized older adults, by assessing for signs, repeating or asking the same thing over and over, or getting lost. During the nursing admission assessment, we assess for these symptoms. Nursing interventions are aimed at promoting patient function and independence for as long as possible. Other important goals include promoting the patient's physical safety, promoting independence and self-care activities, reducing anxiety and agitation, improving communication, providing for socialization and intimacy, providing adequate nutrition, and promoting activity balanced with rest. Supporting and educating family caregivers is also an important role that nurses play. These nursing interventions apply to all patients, regardless of the cause. The emotional burden on the families of patients with all types of dementia is enormous. The physical health of the patient is often very stable, and the mental degeneration is gradual. Family members are faced with numerous difficult decisions, such as when the patient should stop driving, when to assume responsibility for the patient's financial affairs. Now, aggression and hostility exhibited by the patient are often misunderstood by families or caregivers who feel unappreciated, frustrated, or angry. Feelings of guilt, nervousness, and worry contribute to the caregiver, with fatigue, depression, and family dysfunction. The Alzheimer's Association is a coalition of family members and professionals who share the goals of family support and service, education, research, and advocacy. There are family support groups and respite care and adult daycare that can be available through different community resources. Respite care is commonly provided service in which caregivers can get away from the home for short periods while someone else tends to the needs of the patient. Caregivers must learn to distinguish between obligations from those that are not completely necessary. They do not leave the patient home alone, and they may be taught balance and sustainability between the care of self and the patient. With vascular dementia, it is associated with cerebral vascular disease in the form of multiple infarcts or strokes, a single larger infarct, or small vessel disease. It affects approximately 10 to 20% of people with dementia. The rate is higher in men than women and tends to have a more abrupt onset than Alzheimer's disease. Multifarct dementia, the most common form of vascular dementia, has an unpredictable course and is characterized by variable impaired depending on the affected sites of the brain. Because vascular dementia is associated with hypertension and cardiovascular disease, risk factors such as hypercholesterolemia, history of smoking, and diabetes are similar. Prevention and management are also similar. Therefore, measures to decrease blood pressure and lower cholesterol levels may prevent future infarcts. The concept cognition includes the exemplars Alzheimer's disease or dementia, which we'll also discuss vascular dementia, delirium, and Down syndrome. Alzheimer's disease is the fifth leading cause of death for older adults. It is a progressive, irreversible, degenerative neurologic disease that begins insidiously and is characterized by gradual losses of cognitive function and disturbances in behavior and affect. It can occur in people as young as 40 years of age, but is uncommon before 65 years of age. Although the prevalence increases dramatically with increasing age, it affects as many as half of those 85 years and older. It is to be noted that it is not a normal part of aging. Without a cure or any preventative measures, it is estimated that 13.4 million Americans will have this disease by 2050. With the pathophysiology, there are specific neuropathogenic and biochemical changes that are found in patients with Alzheimer's disease. These include neurofibrillary tangles, or senile or neurotic plaques. The neuronal damage occurs primarily in the cerebral cortex and results in decreased brain size. Similar changes are found in the normal brain tissue of older adults, although to a lesser extent. Cells that use the neurotransmitter acetylcholine are primarily affected by Alzheimer's disease. At the biochemical level, the enzyme active in producing acetylcholine, which is specifically involved in memory processing, is decreased. Now, the clinical manifestations show in the early stages are forgetfulness and subtle memory loss. Patients may experience small difficulties in work or social activities, but have adequate cognitive function to compensate for the loss and continue to function independently. With the further progression, the deficits can no longer be concealed. Forgetfulness is manifested in many daily actions. Patients may lose their ability to recognize familiar faces, places, and objects, and they may become lost in a familiar environment. They may repeat the same stories because they forget that they have already told them. The ability to formulate concepts and think abstractly disappears. On a hot day, a patient may decide to wade in the city fountain fully clothed. Patients may have difficulty with everyday activities such as operating simple appliances and handling money. Personality changes are also usually evident. They may become depressed, suspicious, paranoid, hostile, and even combative. With the medical management, the primary goal is to manage the cognitive and behavioral symptoms. There is no cure. There are several medications that have been introduced to slow the progression of the disease. The cholinesterase inhibitors, like Aricept and Exelon, enhances acetylcholine uptake in the brain, thus maintaining memory skills for a period of time. These and other medications are used for mild to moderate symptoms. Cognitive ability may improve within 6 to 12 months of therapy. However, cessation of the medications results in disease progression and cognitive decline. The behavioral problems such as agitation and psychosis can be managed by behavioral and psychologic therapies. Associated depression and behavioral problems can also be treated pharmacologically if other interventions fail. Because symptoms change over time, all patients with Alzheimer's disease should be reevaluated routinely.
The stages of Alzheimer's disease range from stages 1, 2, and 3. Stage 1 indicating that it is a mild case, which lasts between 2 to 4 years. Typically has forgetfulness, restlessness, and some disorientation. Individuals are physically healthy and alert. Stage 2, which is the moderate form of Alzheimer's, it lasts between 2 to 12 years. It consists of memory deficits and are more apparent. Decreased spontaneity, orientation decreases and confusion increases. Changes in personality, coordination, and visual spatial perception. And sundowning. Sundowning is specific to Alzheimer's because what happens is during the nighttime there is increased confusion noted with patients with Alzheimer's. It's important for you to know that during this time in the early stages of Alzheimer's, a lot of mood and affect changes occur. So therefore, in diagnosing patients with Alzheimer's, for Alzheimer's, the nursing diagnoses that you would focus on are risk for injury, self-care deficits, impaired communication, caregiver role strain, imbalanced nutrition, anxiety, chronic confusion, and impaired memory. The goals for Alzheimer's nursing diagnoses are to ensure that the patient will remain free of injury, patient will be able to navigate home environment with modifications as needed, patient will participate in grooming and hygiene, patient will maintain optimal weight, and patient will utilize memory aids such as lists, alarm clocks, and calendars if able to in stage 1 of Alzheimer's.
In Alzheimer's disease, nursing management plays an important role in the recognition of dementia, particularly in hospitalized older adults, by assessing for signs, repeating or asking the same thing over and over, or getting lost. During the nursing admission assessment, we assess for these symptoms. Nursing interventions are aimed at promoting patient function and independence for as long as possible. Other important goals include promoting the patient's physical safety, promoting independence and self-care activities, reducing anxiety and agitation, improving communication, providing for socialization and intimacy, providing adequate nutrition, and promoting activity balanced with rest. Supporting and educating family caregivers is also an important role that nurses play. These nursing interventions apply to all patients, regardless of the cause. The emotional burden on the families of patients with all types of dementia is enormous. The physical health of the patient is often very stable, and the mental degeneration is gradual. Family members are faced with numerous difficult decisions, such as when the patient should stop driving, when to assume responsibility for the patient's financial affairs. Now, aggression and hostility exhibited by the patient are often misunderstood by families or caregivers who feel unappreciated, frustrated, or angry. Feelings of guilt, nervousness, and worry contribute to the caregiver with fatigue, depression, and family dysfunction. The Alzheimer's Association is a coalition of family members and professionals who share the goals of family support and service, education, research, and advocacy. There are family support groups and respite care and adult daycare that can be available through different community resources. Respite care is commonly provided service in which caregivers can get away from the home for short periods while someone else tends to the needs of the patient. Caregivers must learn to distinguish between obligations from those that are not completely necessary. They do not leave the patient home alone, and they may be taught balance and sustainability between the care of self and the patient.
Delirium. Delirium is an acute and serious disorder of cognition. It typically is traced to one or more contributing factors, some which include chronic medical illness, medications, infections, surgery, drug, or alcohol abuse. Delirium results in a decreased awareness of one's environment and confused thinking. This is usually the initial sign of a life-threatening problem. When we talked about sodium deficiencies, we talked about confusion was the first indication for the elderly. This is why delirium is an early indication for any kind of elderly electrolyte imbalances, fluid irregularities, so we need to make sure that we're aware of that. And a lot of times with delirium, it can be reversed if we figure out what the problem is. However, with Alzheimer's, it's something that we're looking at as chronic. So it's very hard to differentiate when someone has Alzheimer's and maybe has. The common assessment findings for delirium consist of altered level of consciousness, disorientation, agitation, emotional mood swings, slurred speech, unsteady gait, confusion, memory and attention impairment, hallucinations and delusions, and restlessness. The plan of care for delirium, the goals that we aim to focus and try to improve, are to improve and make the patient free of confusion, that the patient's cognitive status returns back to baseline, that the patient will perform ADLs, and then all goals, regardless, are focused on promoting independence and providing the patient the opportunity to optimize their functional abilities independently. Some of the nursing interventions for delirium are to collaborate with the medical team to correct the underlying cause, which may be hypoxemia, infection, and electrolyte imbalances. They might need to consider medications and also levels for toxicity and monitoring lab values. The most important thing with delirium is establishing trust and rapport with your patient. Frequent reorientation, utilizing memory aids, using a whiteboard, putting your name on the whiteboard that you're providing care to them, providing them an alarm clock so that they know what time and things, what of activities or when their medications are due. Give clear communication. Treat behavioral symptoms, possible medications, just making sure they adhere to their regular medication regimens. And also, the biggest thing is providing a safe and quiet environment. They don't like a lot of stimulation, so providing an environment. Delirium, as far as evaluation, once the underlying problems are treated, patients should return to pre-delirium state and baseline. So it should either go back to the way it was if they had Alzheimer's. It was a mild case of Alzheimer's and it went from mild to severe. Once we corrected the problem, they went back to their original state. Or if they never had any issues with confusion or level of consciousness, they returned back to normal. So all those things are considered because delirium is not something that's long-term.
With vascular dementia, it is associated with cerebral vascular disease in the form of multiple infarcts or strokes, a single larger infarct, or small vessel disease. It affects approximately 10 to 20% of people with dementia. The rate is higher in men than women and tends to have a more abrupt onset than Alzheimer's disease. Multifarct dementia, the most common form of vascular dementia, has an unpredictable course and is characterized by variable impaired depending on the affected sites of the brain. Because vascular dementia is associated with hypertension and cardiovascular disease, risk factors such as hypercholesteremia, history of smoking, and diabetes are similar. Prevention and management are also similar. Therefore, measures to decrease blood pressure and lower cholesterol levels may prevent future infarcts.
Down syndrome, or trisomy 21, is an extra chromosome which usually has 3 copies of chromosome 21. Patients with trisomy 21 are at increased risk for metabolic disturbances to include diabetes, congenital heart defects, GI conditions like celiac disease, thyroid disease, and leukemia. There are really no known cause for trisomy 21. However, there are risk factors that can allow us to help families to provide them with education before the child is born and prepare for the chronic needs of the child. So a lot of these things would be lack of prenatal care or prenatal screening, advances in maternal ages greater than 35 years of age, if both mom and dad are carriers of the genetic translocation, or if they have a history of having one child with Down syndrome. Those are all red flags that would indicate that these families need extra education and extra preparation for the possibility of having a child with Down syndrome. Down syndrome children actually have a very good outcome as far as development. Very small amount of them are just developmentally delayed, and so a lot of times if we have them, if we are actively involved in assessing them for their developmental milestones, giving them PT, language therapy, occupational therapy, these kids can actually function at their maximum capability. The problem that makes it more difficult, though, is the congenital anomalies. Usually a lot of these kids with trisomy 21 have the heart defects that require extensive repair of their hearts, so this makes them more failure to thrive. However, for the Down syndrome aspect only, the kids are more likely to do better if we are aggressively on top of them for their growth and development and getting them those additional aids as needed. For the Down syndrome child, some of the nursing interventions are for early recognition to enhance optimal functioning, which meaning that getting them the speech therapy needed if they are not progressing the way they should, having a trained professional work with them so that they can start saying 2 to 3 words at 2 years of age. Assessment of development and functioning, just making sure, if there's something that, if they're not able to walk, getting them the physical therapy that they need to help them begin to walk. And now understanding that, that at a year old, usually a person without any congenital anomalies or congenital defects can walk by a year of age, but with Down syndrome, there's no indication that they'll meet that milestone. So just helping them, recognizing that their timetable is different from a patient that has no history of any kind of defects. Assessing for adaptive functioning of the family and child.
The concept tissue integrity includes the exemplars dermal ulcer, impetigo, psoriasis, wounds, which include surgical and traumatic, tinea pedis, candida, and pediculosis capitis, or lice. Once again, please be aware that the reading in the reading list is you are responsible to complete. With the concept of tissue integrity, the exemplar dermal ulcer will be explained. A pressure ulcer is a wound with a localized area of tissue necrosis. Depending on the depth of the ulcer, a pressure ulcer may be an acute wound or a chronic wound. The underlying cause is pressure. Most pressure ulcers develop when soft tissue is compressed between a bony prominence and an external surface for a prolonged period of time, or when soft tissue undergoes pressure in combination with shear and/or friction. The terms decubitus ulcer, pressure sore, and bed sore are also used to refer to this type of wound. The term pressure ulcer is considered the most appropriate term because pressure is the most prominent underlying cause. With pressure ulcer development, there are factors that we can consider. Pathological changes at a pressure ulcer site result from blood vessel collapse caused by pressure, usually from body weight. Necrosis eventually occurs, leading to a characteristic ulcer. 2 mechanisms contribute to pressure ulcer development: external pressure that compromises blood vessels, and friction and shearing forces that tear and injure blood vessels and abrade the top layer of skin. Risks for pressure ulcer development can include friction and shear, and a combination. These include immobility, nutrition, hydration, skin moisture, mental status, and age. With immobility, patients who spend long periods of time in bed or seated without shifting their body weight properly are at great risk for development of a pressure ulcer. With nutrition and hydration, protein, which is calorie malnutrition, predisposes a person to pressure ulcer formation because poorly nourished cells are damaged easily. Protein deficiency, leading to a negative nitrogen balance, electrolyte imbalance, and insufficient caloric intake, also predispose the skin to injury. With moisture, primary sources of skin moisture include perspiration, urine, feces, and drainage from wounds. Prolonged moisture on the skin reduces the skin's resistance to trauma, particularly damage from friction and shear. When skin is damp, less friction is required to blister and abrade skin. Mental status. The more alert an individual is, the more likely he or she is to protect skin integrity by relieving pressure periodically and maintaining adequate skin hygiene. With age, older adults are at a greater risk for pressure ulcer formation because the aging skin is more susceptible to injury. Chronic and debilitating diseases, more common in this age group, may adversely affect circulation and oxygenation of dermal structures. Within the concept of tissue integrity, we will be discussing the dermal ulcers or pressure ulcers and their stages. A stage 1 pressure ulcer is a defined area of intact skin with non-blanchable redness of a localized area, usually over a bony prominence. Darkly pigmented skin may not have visible blanching. Its color may differ from the surrounding skin. The area may be painful, firm, soft, warmer, or cooler as compared to adjacent tissues. A stage 2 pressure ulcer involves partial thickness loss of dermis and presents. A stage 3 ulcer presents with a full thickness tissue loss. Subcutaneous fat may be visible, but bone, tendon, or muscle is not exposed. Slough may be present, but does not obscure the depth of tissue loss. Stage 4 ulcers involve full thickness tissue loss with exposed bone, tendon, or muscle. Slough or eschar may be present on some part of the wound bed and often include undermining and tunneling. The exemplar impetigo is a bacterial skin infection. Impetigo is a superficial infection of the skin caused by Staphylococci, Streptococci, or multiple bacteria. Bullous impetigo, a more deep-seated infection of the skin, is caused by Staphylococcus aureus. It's characterized by the formation of a bullae. The exposed areas of the body, face, hands, neck, and extremities are most frequently involved. Now, impetigo is contagious and may spread to other parts of the patient's skin or to other members of the family who touch the patient or use towels or combs that are soiled with the exudate of the lesions. Impetigo is seen in people of all races and ages. It is particularly common in children living in poor hygienic conditions. Now, chronic health problems, poor hygiene, and malnutrition may predispose an adult to impetigo. The clinical manifestations are lesions that are most commonly seen on the face or extremities. They begin as small red macules, which quickly become discrete, thin-walled vesicles that rupture and become covered with a loosely adherent honey yellow crust. Now, these crusts are easily removed to reveal smooth red moist surfaces on which new crusts soon develop. Now, with the medical management, topical antibiotic therapy is usually prescribed when the disease is limited to a small area. Lesions are first soaked or washed with soap solution to remove the central site of bacterial growth, giving the topical antibiotic an opportunity to reach the infected site. After the crusts are removed, the prescribed topical antibiotic cream is applied. Now, gloves should be worn when providing patient care. Systemic antibiotics can be prescribed to treat infections that are widespread or in cases where they are systemic manifestations and if a fever is present. The nursing management includes when the nurse educates the patient and family to bathe at least once daily with bactericidal soap. Cleanliness and good hygiene practices help to prevent the spread of the lesions from one skin area to another and from one person to another. Patients and family members must be educated to practice hand hygiene every time after a lesion is touched. Each person should have a separate towel and washcloth. Because impetigo is contagious, infected people should avoid contact with other people until the lesions heal. The exemplar psoriasis is considered one of the most common chronic non-communicable skin diseases. It's characterized by the appearance of silvery plaques that most commonly appear on the skin over the elbows, knees, scalp, lower back, and buttocks. Although lesions may appear anywhere, including the oral cavity, eyes, including the lids, conjunctiva and corneas, and joints. Onset can occur at any age with a medium onset at 28 years. It is more prevalent among women and Caucasians and among persons who are obese. It is thought that most patients with psoriasis have a genetic predisposition to develop the disease. Psoriasis has a tendency to improve and then recur periodically throughout life. The pathophysiology of psoriasis, the current evidence supports an autoimmune basis. Periods of emotional stress and anxiety aggravate the condition, and trauma, infections, and seasonal and hormonal changes may also serve as triggers. The clinical manifestations may range in severity from a cosmetic source of annoyance to a physically disabling and disfiguring disorder. The lesions appear as red, raised patches of skin covered with silvery scales. The scaly patches are formed by the buildup of living and dead skin. If the scales are scraped away, the dark red base of the lesion is exposed, producing multiple bleeding points. The patches are not moist and may be pruritic. In many cases, the nails are also involved with pitting, discoloration, crumbling beneath the free edges, and separation of the nail plate. Now, medical management, the goal is to slow the rapid turnover of the epidermis to promote resolution of the psoriatic lesions and to control the natural cycles of the disease. There is no known cure. The therapeutic approach should be one that the patient understands because they will be the ones who are providing the interventions and care. It should be cosmetically acceptable and minimally disfiguring of a lifestyle. Treatment involves the commitment of time and effort by the patient and possibly family. Any precipitating or aggravating factors are addressed. An assessment made of the lifestyle because psoriasis is significantly affected by stress. Gentle removal of scales is an important principle of psoriasis treatment. This can be accomplished by taking baths with added oils. There can be pharmacological therapy. There can be topical, phototherapy, and systemic. In the concept of tissue integrity, the exemplar psoriasis. Complications from psoriasis can include asymmetric rheumatoid factor, negative arthritis of multiple joints, which occurs in up to 30% of people with psoriasis, mostly typical after skin lesions appear. The most typical joints affected include those in the hands or feet, although sometimes larger joints like elbows and knees or hips may be affected. It is recommended that a rheumatologist be consulted to assist in the diagnosis and long-term treatment. Generalized exfoliative dermatitis may also result from psoriasis. There are 3 types of therapy that are commonly indicated: topical, phototherapy, and systemic. Topical applied agents are used to slow the overactive epidermis. Topical corticosteroids may be applied for their anti-inflammatory effects. Phototherapy are for patients who do not respond well to topical treatments. Phototherapy is used by a narrowband ultraviolet B therapy and may be effective as a single therapy modality. However, phototherapy is generally more effective when it is administered as an ultraviolet A in conjunction with photosensitizing oral medication. Systemic agents can be corticosteroids. They may cause rapid improvement of psoriasis. The usual risks and the possibility of triggering a severe flare-up on withdrawal limit their use, though. Therefore, they are not indicated for treatment of psoriasis. Within the nursing management, psoriasis may cause despair and frustration for the patient. Observers may stare, comment, ask embarrassing questions, or even avoid the person. The disease can eventually exhaust the patient's resources. The nurse assesses the impact of the disease on the patient and the coping strategies used for conducting normal activities and interactions with family and friends. The nurse explains with sensitivity that although there is no cure for psoriasis and lifetime management is necessary, the condition can usually be controlled. To avoid injuring the skin, the patient is advised not to pick at or scratch the affected areas. Measures to prevent dry skin are encouraged because dry skin worsens psoriasis. In educating the patient about self-care, printed patient education materials may provide to reinforce face-to-face discussions about treatment guidelines and other considerations. Patients using topical corticosteroid preparations repeatedly on the face and around the eyes should be aware that cataract involvement can be possible. Strict guidelines for applying these medications should be emphasized because overuse can result in skin atrophy, striae, and medication resistance. Some medications produce photosensitivity. If exposure to the sun is unavoidable, the skin must be protected with sunscreen and clothing. Within the concept tissue integrity, the exemplar wound, surgical traumatic, has a wound healing process. There are phases of wound healing. First is the inflammatory phase, then we have the fibroblastic or connected tissue repair phase, and third, the maturation or remodeling phase. Within this wound healing, there is intentions. On the chart 19.4 in Hinkle ebook, there are descriptions about first, second, and third intention. Wounds heal by many different mechanisms depending on the condition of the wound. Surgical wound healing does occur in the three ways: first intention, second intention, and third intention. Within these intentions, first intention, wounds made aseptically, like in surgery, with a minimum of tissue destruction that are properly closed, heal with little tissue reaction by first intention. With second intention healing, they call it granulation. It occurs in infected wounds, like an abscess, or in wounds in which the edges have not been approximated. The third intention is delayed closure. It is used for deep wounds that have not been sutured early or break down and are resutured later, thus bringing together two opposing granulation surfaces. This results in a deeper and wider scar. Within the concept of tissue integrity, with the exemplar wound, surgical traumatic, there will be dressing changes. Although the first post-operative dressing is usually changed by a member of the surgical team, subsequent dressing changes in the immediate post-operative period are usually performed by the nurse. A dressing is applied to a wound for following reasons: to provide a proper environment for wound healing, to absorb drainage, to splint or immobilize the wound, to protect the wound and new epithelial tissue from mechanical injury, to protect the wound from bacterial contamination and from soiling by feces, vomitus, and urine, to promote homeostasis, as in a pressure dressing, and to provide mental and physical comfort for the patient. While changing the dressing, the nurse has an opportunity to teach the patient how to care for the incision and change the dressings at home. The nurse observes for indicators of the patient's readiness to learn, such as looking at the incision, expressing interest, or assisting in the dressing change. Expressing dislike and wanting to delegate this to a family member does not suggest the patient has readiness to learn. In the concept tissue integrity and the exemplar wound, surgical traumatic, there are potential complications. Potential complication is venous thromboembolism. There are serious potential venous thromboembolism complications of surgery, which include deep venous thrombosis and pulmonary embolism. Prophylactic treatment is common for patients at risk for these, and a low molecular weight or low-dose heparin and low-dose warfarin are other anticoagulants that may be used. The next option is early ambulation. Early ambulation and leg exercise help prevent DVT and cannot be overemphasized. These activities are recommended for all patients, regardless of their risk. Adequate hydration is also encouraged. The patient can be offered juices and water throughout the day to avoid dehydration. Another complication is hematoma. At times, concealed bleeding occurs beneath the skin at the surgical site. This hematoma usually stops spontaneously but results in a clot, hence hematoma, formation within the wound. If the clot is small, it can be absorbed, but if it's large, it may bulge somewhat and healing will be delayed until the clot is removed. Sometimes, after several sutures are removed by the physician, the clot is evacuated and the wound is packed lightly with gauze. Infection is another complication. Patient-related factors include age, nutritional status, diabetes, smoking, obesity, remote infections, endogenous mucosal microorganisms, altered immune response, and length of preoperative stay and severity of illness. Wound infection may not be evident until at least post-op day 5. Most patients are discharged before that time, and more than half of wound infections are diagnosed after discharge, highlighting the importance of patient education regarding wound care. The last complication that we'll discuss is dehiscence and evisceration. Wound dehiscence, which is the disruption of surgical incision or wound, and evisceration, which is protrusion of wound contents, are serious surgical complications. These complications result from sutures giving way from infection, or more frequently, from marked distension or strenuous coughs. With the concept of tissue integrity, we will discuss the exemplar Candida. Candidal infections is actually a fungal infection caused by C. albicans. This yeast-like fungus is a normal inhabitant of the gastrointestinal tract, mouth, and vagina. The skin problem results from the release of irritating toxins on the skin surface. It is most always found on the surface of the skin and rarely penetrates to deeper layers of the tissue. Some persons who are predisposed to candidal infections by conditions such as diabetes mellitus, antibiotic therapy, pregnancy, oral contraceptive use, poor nutrition, and immunosuppressive diseases. Oral candidiasis may be the first sign of infection with HIV. C. albicans thrives on warm, moist, interreginous areas, things like between folds or adjacent surfaces of the body. The rash is red with well-defined borders. Patches erode the epidermis and there is scaling. Mild to severe itching and burning often accompany the infection. Severe forms of infection may involve pustules or vesiculopustules. In addition to microscopy, a candidal infection often can be differentiated from a tinea infection by the presence of satellite lesions. But these satellite lesions are maculopapular and found outside the clearly demarcerated borders of the candidal infection. Satellite lesions often are diagnostic of a diaper rash complicated by candida. The appearance of candidal infections varies according to the site. In the concept of tissue integrity, pediculosis capitis is truly a bug problem. The diagnosis is identification of eggs, or in other words, we call them nits. The transmission is direct contact with hair of infested people and wearing personal belongings of infested people, or using things such as their combs and hats. There is an incubation period of laying eggs and hatching. It is 6 to 10 days, and adult lice will appear 2 to 3 weeks later. The clinical manifestations are as extreme pruritus, or in other words, itching. They constantly itch their head. The adult eggs, or nits, may be seen, especially behind the ears and the nape of the neck. The treatment that we utilize is washing their hair with a pediculicide and then combing the nits and the lice from the hair. Pediculosis capitis, or head lice, is very easily transmitted. It is usually with direct contact with hair of infested people, or less commonly can be with personal belongings such as combs and hats of those infested. The incubation period from laying to eggs to hatching is 6 to 10 days. So adult lice will appear 2 to 3 weeks later. Now the clinical manifestations or extreme pruritus is the most common symptom. The adult eggs or nits may be seen, especially behind the ears and the nape of the neck of the patient. The diagnosis is made by the identification of those eggs, and lice with the naked eye is possible. Adult lice are rarely seen, but can be seen. The treatment is to wash hair with a particular side, such as permethrin, or they call it Nix. Careful instructions on proper use of any product should be given, and strict adherence to applications is encouraged. Retreatment is usually recommended depending on treatment used. Now, detection of living lice 24 hours after treatment suggests incorrect use or a heavy infestation, reinfestation, or resistant to treatment. Now, these patients will be in contact precautions because it is easily transmitted. After treatment, we check the hair and comb the nits and lice from hair shafts every 2 to 3 days to prevent reinfestation. We also can manually do with our hands by pulling with the tips of our nails the nits. Now, control measures are to household and other close contacts should be examined, and if infested, they're treated. Bedmates should be treated prophylactically. Now, head lice do not survive long once they have fallen off, and most children can be treated effectively without treating their clothing and bedding, but to help avoid reinfestation, disinfection of clothing, headgear, pillowcases, towels, and other items used by the individual within the last 2 days should be washed in hot water and dried on the hot cycle. Soaking combs and hairbrushes in the pediculicide shampoo or hot water is also recommended. Lice infestation is not a sign of poor hygiene. All socioeconomic groups are affected.